This video will review the pathophysiology of schizophrenia. The content covered here will be on exam 1, although the antipsychotics and their drug action will not appear until exam 2. First, let's start with some definitions. Schizophrenia is a heterogeneous syndrome that's characterized by disorganized thoughts, delusions, hallucinations, inappropriate affect, and impaired psychosocial functioning. Psychosis is a symptom characterized by a distorted sense of reality. Psychosis is a symptom of schizophrenia, but is also a symptom of many other neurologic and psychiatric disorders. A hallucination is a sensory perception that is disconnected from real external stimuli. An example of a hallucination is hearing voices. A delusion is a belief about something real that is not true. So if you take something real, like your family, and you have a belief about them that is not true, like your family wishes to hurt you, that would be considered a delusion. Hallucinations and delusions are characteristic of individuals with schizophrenia. The lifetime prevalence of schizophrenia worldwide is on the order of 0.25 to 0.6%. While this is a small percentage of individuals, schizophrenia has no divisions based on race, class, gender, socioeconomic status. It really can affect all groups equally. The onset of schizophrenia is typically in late adolescence or early adulthood, really around the college years is the best way to describe it. Schizophrenia onset very rarely occurs before adolescence or before age 18 or after age 40. The prevalence of schizophrenia is approximately equal in males and females. However, the onset or the age at which the first episode occurs is typically earlier in males than in females. Schizophrenia is one of the most heritable psychiatric diseases, if not the most. The percent contribution of genetics to the pathophysiology of schizophrenia is on the order of 65 to 80%. As demonstrated by the figure on the screen, from twin studies and other genetic studies, you can see that individuals have a much greater risk of developing schizophrenia if they have an identical twin with schizophrenia, if they have two affected parents, or an immediate family member, including a parent or sibling. The specific genes involved in the etiology of schizophrenia are complicated, but do include genes that affect glutamate signaling and synaptic pruning, two processes which are important for the pathophysiology of the disease. The best way to describe the etiology of schizophrenia is that it is a multifactorial disease. There are multiple abnormalities on top of underlying genetic risk that produce variable but similar clinical phenotypes that we've characterized all as a single disease known as schizophrenia. One thing to note about the etiology is that even though environmental and social factors can influence the progression of schizophrenia, there's not a known environmental trigger like an infection or illness or something of that nature that predisposes to schizophrenia. It is thought that, in fact, schizophrenia is a neurodevelopmental abnormality, and that as early as the second trimester of pregnancy, a fetus could develop changes or factors that could be predisposed to developing schizophrenia later in life. On top of this, other birth factors such as low birth weight, obstetric complications, and neonatal hypoxia all increase the risk for developing schizophrenia. To sum this up, underlying genetic risk produces vulnerable synapses, which combined with a process known as synaptic pruning that I will talk about in a few seconds, leads to the development of schizophrenia in the adolescent and early adult years. The underlying pathogenesis of schizophrenia is thought to be excessive synaptic pruning. Synaptic pruning is a process that normally occurs during the adolescent period, and it is thought that individuals with schizophrenia exhibit excessive synaptic pruning. This is corroborated by the fact that the timing of normal synaptic pruning coincides with the typical age of onset of schizophrenia. Normally, we are born with more synaptic connections than we truly need, and these synaptic connections are molded and added and subtracted and formed and reformed over time to get the most efficient neuronal communication possible. Issues with this process of neuronal communication and synaptic pruning are thought to lead to schizophrenia later in life. Therefore, schizophrenia can be thought of both as a neurodevelopmental disorder, as we discussed previously, but also as a disease of impaired neuronal connectivity. It is not a neurodegenerative disease because there is not a decrease in neurons. Rather, there is a problem with the way that neurons are connected to one another. One of the characteristics of schizophrenia that can be observed by neuronal imaging has to do with this excessive synaptic pruning. When you have too much synaptic pruning, you can lose dendritic arbors and spines on neurons in the brain. This leads to neurons having smaller cell bodies and being able to more densely or tightly pack within the brain. This denser cell packing leads to thinning of cerebral cortical gray matter, also known as the gray matter of the cortex. This thinning of cerebral gray matter can be observed with neuroimaging, as demonstrated in the brain slices in Part A and the graphic in Part B. Individuals with schizophrenia have lower whole brain volume and specifically decreased cortical volume because of this denser cell packing and less synaptic connectivity. Over the course of a lifetime in a healthy control, there will be a decrease in brain volume normally, but you can see that this process is significantly enhanced and accelerated in individuals with schizophrenia. The functional consequences of this excessive synaptic pruning leading to reductions in cortical volume are not really known, but one of the thoughts is that this somehow leads to abnormal or dysfunctional dopamine signaling. This is known as the dopamine hypothesis of schizophrenia and is realistically a vast oversimplification of the pathophysiology of the disease. Nevertheless, it's worth discussing because of the fact that all available antipsychotics are effective dopamine receptor antagonists. The dopamine hypothesis of schizophrenia essentially states that increased dopaminergic signaling predisposes to the development of the signs and symptoms of schizophrenia. This was discovered in the 1950s when chlorpromazine was synthesized in the search for new antihistamine drugs, and it was determined that chlorpromazine, which blocks dopamine receptors, was effective as an antipsychotic treatment. Thus began the dopamine hypothesis of schizophrenia, where decreasing dopamine signaling in specific dopaminergic pathways is effective in the treatment of schizophrenia. The graphic on the screen demonstrates this relationship. Across the x-axis is the ability of the drug to control the symptoms of schizophrenia, whereas on the y-axis is the affinity of the drug for the dopamine D2 receptor. As you can see, drugs with higher affinity at the dopamine D2 receptor control the symptoms of schizophrenia very effectively. It is this direct and very characteristic relationship that brings dopamine front and center in the pathophysiology of schizophrenia. Given the important role of dopamine, it is important to understand the dopaminergic pathways in the brain and the way that they are affected in the disease of schizophrenia, as well as ways in which they are targeted by antipsychotic drugs. There are four primary dopamine pathways in the brain: mesocortical, mesolimbic, nigrostriatal, and tuberoinfundibular. All four dopamine pathways are affected either in schizophrenia as a disease state or by antipsychotic drugs that are used to treat the disease. The mesocortical pathway is shown in yellow. This originates in the brainstem and projects to areas of the cortex. It is thought that a decrease or a deficit in dopamine signaling in this brain region is associated with the negative symptoms of schizophrenia. The mesolimbic dopamine pathway also originates in the brainstem and projects to the limbic system, like the hypothalamus. This is the dopamine pathway that is also implicated in substance use disorder. It is thought that an excess of dopamine in this pathway produces the positive symptoms of schizophrenia. We will discuss the positive and negative symptoms of schizophrenia in a moment. The nigrostriatal pathway originates in the substantia nigra and projects to the striatum. This pathway is typically characteristic or characterized for its effects in Parkinson's disease. And although it is not affected in the disease schizophrenia, it is affected by antipsychotic drugs. We will discuss this when we go through the antipsychotics in a later video. Lastly, the tuberoinfundibular pathway is a neurohormonal pathway. This originates also in the brainstem and projects to the pituitary, where it controls the release of various neuroendocrine hormones. Again, this pathway is not typically thought to be disrupted in schizophrenia, but it is affected by antipsychotic drugs, which we will discuss later. Dopamine, however, is not the only neurotransmitter thought to be involved in the pathogenesis of schizophrenia. Two other neurotransmitters that might play a role are glutamate and serotonin. Some evidence for the role of glutamate comes from the fact that there are known genetic abnormalities in glutamate-related genes that predispose to schizophrenia. In addition, antagonists of the NMDA receptor, like ketamine, produces a model that very closely mimics schizophrenia better than any dopamine model that has been tried. Given that ketamine administration mimics the signs and symptoms of schizophrenia, it is clear that glutamate signaling plays a role in the expression of symptoms, although it's not known how this plays a role in the pathogenesis of the disease. Another factor related to the role of glutamate is the fact that the prodromal phase of schizophrenia is associated with decreased glutamate signaling. It is thought that decreased glutamate signaling during the prodromal phase of schizophrenia leads to a compensation by decreasing GABA to balance excitatory and inhibitory neurotransmission. This decrease in GABA signaling leads to a subsequent dysfunction of dopamine signaling, and that would initiate or lead to the first exacerbation or episode of psychosis. Another neurotransmitter thought to play a role is serotonin. The primary rationale for this is the fact that serotonin agonists are able to produce hallucinations, similar to hallucinations experienced by patients with schizophrenia. One example of this is LSD, which is a serotonin 5-HT2A receptor agonist. In addition, it is known that 5-HT2A receptors modulate the activity of many other neurotransmitters, including dopamine, glutamate, GABA, acetylcholine, and norepinephrine. And as you'll see when we talk about antipsychotics, many of the antipsychotic drugs have activity at serotonin receptors. Again, the relevance to the pathophysiology is not clear, but what is known is that serotonin plays a role in the expression of psychosis-like symptoms. Although there is significant variability in the clinical presentation of schizophrenia, there are a few factors that are in common. The first is the presence of a prodromal period or prodromal phase. This is a period of time early on in the course of an illness where an individual might experience some odd or strange or changing symptoms or behavior. The prodromal period typically occurs during the high school period of time, and approximately 1/3 of individuals who experience prodromal symptoms will go on to remit and remain what would be considered normal in terms of reality perception. Another 1/3 of individuals who experience prodromal symptoms will maintain subthreshold psychosis-like symptoms, whereas the final one-third of individuals will go on to experience full psychosis and potentially be diagnosed with schizophrenia. The prodromal period is characterized by symptoms like declining school performance, social isolation, unstable mood, irritability or anxiety, and odd or eccentric thoughts. The difficulty is that this is the period of time in high school when many individuals are exhibiting odd or new behaviors anyway. And these prodromal symptoms are often difficult to distinguish from depression and drug use, among other psychiatric diseases. And therefore, it's very difficult to recognize this prodromal phase of schizophrenia until a full blown psychotic episode later in life. The first episode of psychosis is typically sudden in onset and is most commonly associated with symptoms including hallucinations, delusions, alogia, which is lack of speech or decreased speech, flat affect or apathy, hostility and aggression, a lack of self care, and various sleep and appetite disruptions. This psychotic episode will typically remit even on its own without drug treatment, but there are usually residual features on remission, and these can include symptoms like anxiety, suspiciousness, and lack of motivation or lack of judgment. Individuals who do progress to full psychosis typically have comorbid diseases like substance use, depression, anxiety, and other medical or health-related disorders. The most common substances abused by individuals with schizophrenia are either alcohol or polysubstance use. The symptom clusters of schizophrenia are divided into four main areas. These include the positive, negative, mood, and cognitive symptoms. All symptoms can be present at some point during the course of the illness, although some may be more likely to be present during a psychotic episode, whereas others may be more likely during a remission period. The positive symptoms are what we typically associate with schizophrenia, and these include suspiciousness, delusions, hallucinations, and disorganized thinking, speech, and behavior. The negative symptoms can also be very problematic, and these are actually what is associated with poorer function for individuals with schizophrenia. These include symptoms like flat affect or apathy, alogia, which is lack of speech, avolition, which is lack of motivation, and anhedonia. The mood symptoms are typically things like dysphoria, suicidality, and feelings of hopelessness, which most closely resembles a depressed mood. And finally, the cognitive symptoms are also associated with poorer function, and these include things like impaired attention, working memory, and executive function, like problem solving and decision making. Of the antipsychotic drugs that are used to treat schizophrenia currently, most of these drugs target the positive symptoms of schizophrenia, and there are very few, if any, drug treatment options for the negative and cognitive symptoms. A diagnosis of schizophrenia is made by observation and medical history using the Diagnostic and Statistic Manual of Mental Disorders, 5th edition. The DSM-5 criteria for schizophrenia are displayed in this graphic. There are a few criterion that are labeled with letters A through F, and each of these criterion must be present for a diagnosis of schizophrenia to be made. The AID criterion is the primary one, and this states that 2 or more of the listed symptoms must be present for at least 1 month, including delusions, hallucinations, disorganized speech or behavior, and the various negative symptoms that we've discussed. The B criterion is that there should be a level of functioning that is significantly decreased in work or personal life and or personal care. C criterion is that the symptoms have lasted at least 6 months. D is exclusion of schizoaffective disorder, which we won't talk much about, but is similar to schizophrenia and has different diagnostic criteria. Also under criterion D would be exclusion of unipolar depression and bipolar disorder. E is that the symptoms cannot be attributed to the use of drugs or medication or to another underlying medical disease. And F is that in the case of pre-existing autism spectrum disorder, there has to be at least 1 month with prominent hallucinations or delusions. Unfortunately, the long-term prognosis for individuals with schizophrenia is rather poor. As demonstrated on this graphic, the standardized mortality ratio of individuals with schizophrenia from 1999 to 2006 has actually slightly increased. One of the hardest issues in terms of schizophrenia is the fact that treatment adherence is very difficult to obtain. Individuals typically experience intermittent psychotic episodes with impaired psychosocial functioning between episodes. And in terms of ways in which schizophrenia is expressed, individuals who experience predominantly negative symptoms tend to have a poorer prognosis because those symptoms are harder to treat. I didn't want to end on a negative note. So, what I wanted to show here is some information about the future of schizophrenia diagnosis and treatment. If you divide the stages of schizophrenia into 5 stages: initial risk, prodromal phase, acute psychosis, and chronic psychosis, there are several diagnostic needs and requirements for improved outcomes that are starting to be implemented already and at least have been identified, which should over time eventually lead to better ability to diagnose and treat the disease. So, for example, the risk phase, which is characterized by genetic and environmental risk when patients are typically asymptomatic. If there was a genomic risk score and public health measures implemented, this could assist with earlier diagnosis and improved outcomes for patients. In the prodromal phase, which is associated with cognitive and social deficits, and the phase at which many individuals seek help, if there were better predictive biomarkers to identify schizophrenia compared with other similar disease states like depression, and safe and effective treatments for prophylactic or preemptive treatment, this could also help. For acute psychosis, which is characterized by relapsing and remitting and higher suicide risk, better deconstruction and division of psychosis into multiple different syndromes with specifiers could assist in diagnosis and choosing the right therapy for patients. And in chronic psychosis, which is associated with medical complications and disability, needs for rehabilitation and treatment of comorbidities, as well as detection of comorbid conditions, can assist with treatment during this phase. There are several studies and new therapeutics in clinical trials, and these will continue to be ongoing in the search for better diagnostic and treatment modalities for schizophrenia. Now would be a good point to pause, review what we've learned by completing the schizophrenia and bipolar pathophysiology assignment that's posted in Canvas. You can scan a photo of the QR code to access the assignment.